The diagnosis and management of patent ductus arteriosus varies significantly based on the patient's age, ranging from the extremely preterm neonate to the adult, and the hemodynamic impact of the shunt. The clinical hallmark of a hemodynamically significant PDA is a continuous missionary murmur heard best at the left upper sternal border. In neonates and infants with large shunts, other findings include bounding pulses due to a wide pulse pressure from diastolic runoff into the pulmonary circulation, active precordium and signs of congestive heart failure, tachypnea, poor feeding, failure to thrive. Differential cyanosis if pulmonary hypertension leads to a right to left shunt affecting the lower body more than the upper body. Transthoracic echocardiography is the definitive diagnostic tool. Key parameters used to assess hemodynamic significance include ductal diameter, often measured at the narrowest point, pulmonary end. A diameter more than 1.5 mm in preterm infants is often considered significant. Shunt direction and velocity. Predominantly left-to-right flow with low velocity suggests a large unrestrictive ductus. LA aorta ratio. A left atrium to aortic root ratio more than 1.5 indicates significantly high pulmonary blood flow and left heart volume overload. Diastolic flow reversal. Retrograde flow in the descending aorta or mesenteric arteries indicates ductal stele compromising systemic perfusion. In recent years, particularly for preterm infants less than 32 weeks, there has been a significant shift toward conservative or expectant management. Emerging trial evidence suggests that early routine pharmacological closure does not improve outcomes like bronchopulmonary dysplasia or mortality, and may in some cases be associated with increased risks. Conservative measures include fluid restriction and optimized PEEP or ventilatory support. Wait and watch approach, as many PDAs close spontaneously even in extremely low birth weight infants. Pharmacological closure indicated primarily in symptomatic preterm infants when conservative measures fail. NSAIDs, indomethacin and ibuprofen, are traditional first-line agents. They act by inhibiting prostaglandin synthesis. Paracetamol, acetaminophen, increasingly used as an alternative with a potentially better safety profile regarding renal and gastrointestinal side effects, though its efficacy compared to ibuprofen remains a subject of ongoing clinical debate. Transcatheter device closure. This is the procedure of choice for most children and adults. Devices. Tools like the Amblatzer Piccolo occluder have expanded the feasibility of percutaneous closure to very low birth weight infants, that is more than 700 to 800 grams. Technique usually performed via venous access antegrade or arterial access retrograde. Recent data highlights the safety of venous-only access to minimize arterial complications in small infants. Surgical ligation is reserved for cases where transcatheter closure is technically impossible, such as extremely small infants where even specialized devices cannot be safely deployed. Ductal anatomy, example very short or window-like, that is not amenable to device occlusion. Failure of medical therapy in a critically ill neonate. The PDA randomized clinical trial. This multicenter randomized clinical trial published in JAMA randomized 482 extremely preterm infants to either expectant management or active treatment, ibuprofen, indomethacin or paracetamol. The study found no significant difference in the composite primary outcome of death or bronchopulmonary dysplasia at 36 weeks. Critically, mortality was significantly lower in the expectant management group, 4.1%, compared to the active treatment group, 9.6%, with a lower incidence of infections resulting in death in the expectant group. A meta-analysis of 10 RCTs involving 2,035 infants published in JAMA Pediatrics found that the incidence of death or moderate to severe bronchopulmonary dysplasia was higher in the active treatment group compared to the expectant management group. The Ductus trial is a landmark study that has fundamentally challenged the long-standing rush to close approach for patent ductus arteriosus in extremely preterm infants. Expectant management was found to be non-inferior to early ibuprofen treatment. The primary outcome occurred in 46.3% of the expectant management group compared to 63.5% in the early ibuprofen group. The composite primary outcome included necrotizing enterocolitis, Bell's stage 2A or higher, moderate to severe bronchopulmonary dysplasia, or death at 36 weeks post-menstrual age. It was a multi-center non-inferiority trial of infants with echocardiographically confirmed PDA diameter more than 1.5 mm with left to right shunting, who were extremely preterm, less than 28 weeks gestational age. The baby Oscar outcome after selective early closure of arterial duct trial is one of the definitive studies that helped shift neonatal practice toward a more conservative approach regarding patent ductus arteriosus. There was no significant difference in the composite outcome of death or moderate to severe bronchopulmonary dysplasia at 36 weeks of post-menstrual age. The trial reinforced that early treatment with ibuprofen does not provide a clear clinical benefit over waiting, even when the PDA appears hemodynamically significant on early echocardiography.